Good morning and welcome to Pediatrics Grand Rounds. Before I introduce today's incredible speaker, we want to ask you to take the evaluation at the end of today's session. You'll find a link in your email or as a QR code at the end of the slides. We would like to invite you to turn on your cameras to join us in community for our session today. Now I have the distinct pleasure of introducing Dr. Ryan McAdams, a UW neonatal intensivist, artist, and AI researcher. His career has taken him from performing an emergency C-section by generator light in a Ugandan bush hospital to training neural networks that can spot a newborn's airway in just microseconds. This convergence defines his mission that every baby, everywhere, deserves the best care. A former Air Force physician with global health experience across 4 continents, Dr. McAdams has witnessed medicine's stark inequalities, from village clinics in Cambodia to Mongolia's remote hospitals. These experiences shaped his commitment to democratizing critical care and advancing neuroprotection for the world's most vulnerable patients. As professor of pediatrics at the University of Wisconsin and co-founder of NeoMind AI, Dr. McAdams develops computer vision systems that guide neonatal procedures and detect physiologic patterns invisible to the human eye. His research, spanning bench research, translational studies, and clinical trials, focuses on preventing perinatal brain injury and optimizing neurodevelopmental outcomes, work driven by the belief that every newborn deserves the best possible start in life. His innovations are guided by a simple philosophy: sophisticated technology should serve universal access, ensuring that survival and optimal brain development don't depend on geography. Today, Dr. McAdams will be presenting Designing for Downstream, the Long Shadows of Innovation. Welcome, Dr. McAdams, and thank you.
Good morning. Thank you, Nikki. Appreciate that. Okay, well, welcome to Pediatric Grand Rounds. So I want to start by acknowledging some remarkable people. So first, the incredible team in the Division of Global Pediatrics. So I get to work alongside colleagues who are very passionate about children. I know all of you are. The global health divisions, I think, just great to work with. And they certainly believe that meaningful work and joy can coexist. I also want to thank Dr. Williams for supporting our division. So I want to emphasize just how critical this work is. So arguably more urgent now than at any point in recent memory. And then to Kate and Reva and everyone who made today's Grand Rounds possible, thanks for creating the space for us to gather and learn together. So regarding the talk today, I'll be focusing on AI and how it applies to global health. And I want to begin with a quote from Mahatma Gandhi. The quote is, "The future depends on what you do today." So this sentiment isn't just meant to be inspiring, it's the foundation of everything we'll discuss this morning. Because in global pediatric health, today's actions don't just matter, they determine which children will thrive, which communities will flourish, and what kind of world we'll be leaving behind. So today we'll talk about innovations and efforts that hopefully will improve tomorrow. And so some of the art I'll be using and some of the things were mine generated with various types of generated AI. This is my conflict of interest. And then if you could just take a minute at the end to fill out an evaluation, I think that's really helpful. So we only get better with feedback. So I want to begin with a number. So 6,400. That's how many newborns will die today, and mostly from causes that we know how to prevent. As a perspective, Meriter Hospital, where I'm working this week, we're the busiest delivery hospital in Wisconsin, and we deliver 5,000 babies per year. So think of that number, 6,400, and what that looks like. So global child mortality has dropped dramatically over the past 2 decades, but that progress is slowing and inequity is widening. Neonatal deaths make up half of all the under 5 deaths, and nearly every one of these is in low and middle income countries. So the decisions governments make related to health, what they fund, what they don't fund, what they design, who they include or exclude, cast very long shadows. In the US, current decisions about science funding and vaccine support will likely have ripple effects across generations. Globally, the same is true with programs like USAID. So when health resources shrink, so does hope for millions of children. But now imagine a technology that could bring specialist level diagnostics to any rural clinic with a smartphone, which pretty much everybody has. This could work 24/7, never get tired, and cost little to scale. So this technology exists, and it's called artificial intelligence. But the real question isn't, what it can do. For me, it's who's it going to help? So is AI going to help children dying in Uganda or just make healthcare faster in Boston? So right now in society and medicine, we're at a crossroads where the influence of AI is radically and rapidly shaping the world around us. The landscape is changing pretty much, it feels like daily. And throughout history, we've had moments that changed everything. The discovery of fire, the wheel, electricity, penicillin, the web. But AI is different. It's the first invention that can invent. The printing press could print a book, but it couldn't write a book. We now generate 18 million gigabytes of data every minute. So companies are harnessing that data with models that can reason, learn, and create. Since late 2022, we've witnessed an acceleration in technology unlike any other. First with ChatGPT, then others that followed like Gemini and Claude. Google's AlphaFold alone compressed decades of protein research into months, and its creators won the Nobel Prize. DeepMind's Graph Networks for Materials Exploration, or GNOME, discovered 2.2 million new crystals, including 380,000 stable materials that could power future technologies. That's 800 years worth of human progress in a single year. So AI is already outperforming humans in pattern recognition. It's very good at taking complex nonlinear data and recognizing patterns. So in fields like radiology, pathology, fetal monitoring, retinal imaging, it can excel. It can summarize years of chart data in seconds and flag patients at risk for sepsis hours before we would detect it. So this saved time potentially frees us to do what only humans can do, how we connect with our patients, provide comfort, and weigh in on decisions where the data disagrees. So this is a typical fundus photograph. So we can identify the optic disc, the vessels, the macula, and the fovea. So if we take retinal imaging as an example of where AI is moving us, the eye is a window into the body, and with the help of pre-trained AI algorithms, retinal scans can now reveal far more than just eye disease. They can predict risk factors and diagnose conditions across nearly every system: cardiovascular disease, diabetes, blood disorders, kidney and liver diseases, even psychiatric and neurodegenerative conditions. And it goes beyond diagnosis. With longitudinal training, these models can detect disease early, anticipate future events, and even predict prognosis. So with the arrival of generative AI, we're entering an entirely new phase in medicine. So the potential to transform healthcare is enormous, turning a simple retinal image into a powerful tool for prediction, prevention, and precision medicine. For context, the common imaging modalities you may hear referenced include color fundus photography, ocular coherence tomography, as well as ocular coherence angiography and ultra wide field imaging, all of which AI can leverage with remarkable accuracy, which has now created this field of oculomics. So with AI, the image becomes a window into the entire body. These models can predict an impressive range of diseases, from atherosclerosis to Alzheimer's. So it's astonishing with one picture, just in a second, and suddenly the eye tells the story of the heart, the brain, and the mind. And these are just a list of some of the diseases that have been identified just by looking into the eye. So for me, bringing it closer to home, let's say the NICU, what about digital twins? So this is something that's being actively worked on in different capacities. So you could have a digital mimic of an organ, but you could do a whole system like a whole person. So a living learning model that evolves with every heartbeat, every blood gas, every ventilator change. So at first it simply monitors, but then it can predict and then simulate. And it lets us test interventions virtually before we ever touch the patient. So it could do literally billions or trillions of equations, run different algorithms for a desired output. There's different levels that have been proposed for this. When you hit to level 4, that's like the environment itself. It's sensing oxygen exposure, light, noise, parental touch. And at level 5, it becomes explainable, showing us why a baby's at risk, not just that they are. So that's the kind of precision medicine I think we've always dreamed about, not reacting to something, but actually anticipating it. So with some of the advances too, with augmented reality glasses, learning or teaching anatomy takes an exciting new path. So this could happen in a hallway, at the bedside, doing a procedure or surgery. So do you want to teach about the brain? Just pull up an image of the brain. Do you want to teach about the heart or the kidney? Just pull those images up. So this is an image of a surgeon looking at a cinematic rendered hologram of a patient's heart with dextrotransposition of the great arteries using something called HoloLens. So you can imagine if, these glasses become hopefully more fashionable than that and easier to wear, which they are, having some of these just at the bedside or for parents or patients, some of the teaching that you could do would be pretty amazing. So in the future, you might get called to a code or a patient's bedside while on call. Imagine you show up, you're able to put on some glasses, and all the patient's information just comes up right in front of you. It's available immediately to get you up to speed with what's going on. So it could demonstrate demographic information, medical information, vital sign trends, give you dosing weights, help with diagnostics and guide treatment, all right there to get you up to speed. So I'm going to talk about some of the research that I've been doing. So with neonatal intubation, it's one of our most delicate procedures we perform where every second can matter. So our team set out to explore whether AI could help clinicians recognize the glottic opening faster. So we got to find those vocal cords. And we wanted to do this more accurately during video-assisted intubation. So we used 84 real neonatal intubation videos, and we trained a deep learning model called YOLO V8 on over 1,600 carefully annotated frames to automatically detect the glottic opening. And when tested, the model identified with strong precision about 81%. And it did so roughly a third a second faster than the average medical provider, performing on par with experts and outperforming novices. So the takeaway is not that machines will replace us in doing procedures, at least not right now, but that AI can act as a second pair of eyes. It can augment safety and shorten learning curves and help ensure that fragile newborns receive critical support with greater confidence and speed. Um, so along with Patrick Pebbles, so Patrick and I worked on that previous project, and now we have one of our fellows, Somi Singh, who's going to help us. We were actually just brainstorming about this at Sino last night, some of our future projects. We want to continue to work in this area, this space with video laryngoscopy and deep learning to help guide endotracheal placement. And we want to do this with simulation training and to improve how we're using video laryngoscopy. So these are like skills that we can simulate and then they can translate into the real world. And the goal here is really to have every intubation be successful, efficient, and safe. So I'm going to show you a test video. This is just from the previous paper. So this was a test video that was not seen by the model during training, so it was brand new to the model. And what you're going to see is the model is going to label anatomy as the person tries to intubate the baby. So it's going to put bounding boxes on the areas of interest. So it's locked in on the cords. So the reality is, despite finding the target, sometimes the tube doesn't always go in. So we'll have to work on that in the future as well. But it just shows you kind of how you can identify anatomy. And when you think about intubating a 22-week infant who weighs the same as a can of Coke, a few millimeters can mean the difference between saving a life and losing the view. So even with video laryngoscopy, knowing exactly how far to advance the blade during intubation can be a challenge. So then we did a second project, which will be published soon, aimed at creating a deep learning model that would help us know where the blade is positioned in the airway. So to build this model, we collected over 100 real neonatal intubation videos that were recorded in our two NICUs using a CMAC video laryngoscope. Just lost my view for a second. Sorry. I'm getting all these notices about meetings. And I'm back. Okay. So in this case, to build this model, we looked at hundreds of videos, and in each video, we carefully reviewed and labeled frame by frame the areas of interest. And so this was Dr. Pebbles and me again. And so we identified where the blade was in, whether it was too shallow at the glottic opening or too deep. So we had over like nearly 300,000 labeled frames that were then used to train the 3D convolutional neural network. So this is a deep learning architecture that analyzes both space and time. So it doesn't just see an image, it understands motion. So the model learned to classify insertion depth in real time, only using the visual data from the video. And we validated its performance using cross-validation to ensure the results were consistent. And so in this model, essentially, what we were able to do here is the model can identify kind of where the blade is and tell you too shallow or kind of just right or too deep. We didn't have a whole lot of instances where it was too deep, so it didn't perform as well there, but it performed well with the shallow. So next steps would be further helping you guide you even more. So like, are you too far to the right? Are you too far to the left? And kind of give you some further information as far as how to place your blade to do a successful intubation. And with this model too, we also just asked providers kind of like, what kind of feedback they would like. And so, they really don't want something that's too loud or noisy. They want something that you could shut off, but having something show up on the screen to tell you where your target is and give you some guidance is something that we think could help folks in the future to make this procedure more successful. So now switching gears to some of the work I've done with virtual reality. So, when we go to a delivery, that first breath, that's this moment of kind of hope and urgency, where some babies were just waiting for them to breathe, some cry right away. The skill of the team at the bedside can make a huge difference in some of these scenarios where the baby's not breathing. But across the world, not every hospital has access to high fidelity simulation centers or formal resuscitation courses. So we asked, what if virtual reality could bridge that gap? So one of our former fellows, Sarah Trin, who's originally from Vietnam, and Sarah was really interested in virtual reality, so we partnered together on this project. And she went to Vietnam for a month. And so she was at Ho Chi Minh City Children's Hospital. And we piloted a VR-based neonatal resuscitation program that immersed doctors and nurses and allied health staff inside a virtual delivery room that we developed that mimics actually the one at Meriter. And then we practiced doing some of the steps of NRP, Mr. SOPA. So how do you improve on ventilation? So we use these meta headsets and an NRP guided scenario, and we trained 28 clinicians, conducted bilingual sessions, and found pretty much universal enthusiasm. Every participant recommended the experience, and most felt like it was more realistic than traditional training. So we showed this that VR is not just a game, it's a potential global equalizer capable of bringing education to pretty much anywhere where you can get Wi-Fi if you have a headset and a computer. So for this, I'm going to show you a video. So I was in my basement and I would get on Zoom, and Sarah was in Vietnam at the hospital, and I would introduce myself to the doctors there that she was with. And then we would hop on VR and I would do some teaching, and she helped with a translation. So this is just a video kind of demonstrating a small portion of that. The first thing you want to do is just adjust the mask, and that's the M's. M is for mask. So that's what we're gonna start with.
Rồi, thì bình thường á, khi mà một em bé ra mà em bé không có thở thì mình sẽ bóp mát đúng không?
We want to go through those steps in that order to try and help the baby breathe.
Đó, rồi giờ chúng ta lần nữa nè. Ngón trỏ lần nữa. Giật lại ngón trỏ một lần nữa bé. Thế là tư thế chưa đúng rồi đúng không? Ngón trỏ.
So you take it like this, squeeze.
Hiểu đó. Rồi dần thử đi vậy.
Đó. Và thở tìm chấm hai này. Và thở. Và thở.
So the goal with this is to continue to build upon that. I mean, my vision is you'd have a international virtual hospital for all types of medicine that you could use for different types of training and teaching. And it wouldn't just have to be US centric. It could be really like more of a global hospital. So a wide array of different diseases and folks contributing to building it. So that's the hope with that moving forward in the future. So I want to shift just to some other technologies just to kind of show you. I'm just giving you some samples of what's going on in different settings, because I think often we have a misconception that a lot of the technology can only happen in high-income countries, but really that's not the case. So innovation isn't just happening in high-tech labs, it's emerging in some of the more resource-limited settings. So this was a study out of Ethiopia. So this is, they showed with like a $60 soft nanomembrane wearable continuous monitor on newborns. It could do ECG, respiratory rate, temperature, and oxygen all in one that would be connected to the phone. And so this is a way they can use technology that, like with a phone, and then not a huge amount of cost if you think of what all those other devices would cost separately, but allow them to monitor patients. And so the majority of parents liked it. And, you know, this is an example where kind of innovation can meet equity. And so furthering this technology, I think, is really exciting in some of these different settings for monitoring. So in East Africa, researchers analyzed 12,000 children to predict who was developmentally on track. And so their best model was a hybrid of a random forest model and an extreme gradient boosting model. And with this, they reached about 66% accuracy. So this isn't ready to clinically roll out, but it was interesting. Some of the strongest predictors were they were not genetic markers or lab values. They were maternal education and household wealth. So AI didn't just find patterns, it kind of held a mirror up to inequities. But I think with data, a lot of these models then can discover data like this that can kind of help inform us as providers and folks locally of what's placing kids at risk. And some of these may be modifiable, some may not. So let's talk about blindness. So specifically retinopathy of prematurity. So each year, an estimated 20,000 infants, mainly from low-income and middle-income countries, experience ROP-related visual loss. And when we talk about children at risk for blindness from ROP, it's mainly preterm infants. So of the 150 million births that happen globally every year, around 15 million of these are preterm babies, so babies born early. And most of these are going to actually happen in low and middle income countries. So smallest babies often have the fewest resources. So in places like India, with a population of 1.451 billion, there's dense cities and there's also vast rural regions. So you can imagine trying to screen millions of these fragile infants for a disease that can steal their sight within weeks. But the reality is India has about 2,000 retina specialists in total, but only 200 of them are trained to treat ROP. So 1.45 billion people and 200 can treat ROP. So in the US, though, our situation isn't perfect here. We also have kind of limited retinal specialists with only a fraction having trained with ROP. So whether you're in Mumbai or Miami, the problem's the same. There's a lot of babies and not enough experts or time. And then one of the other challenges, cameras cost a lot. So some of these retinal cameras can cost as much as $100,000, which is an impossible price tag for hospitals already stretched thin, making a vital resource inaccessible when it's needed most. So then enter KidRop. So this was were technicians that were trained to capture retinal images in remote clinics, and then they transmit that information to a city where experts are. So thousands of babies have kept their sight because of this simple yet brilliant system. So, often these babies could disappear from care, appointments could be missed, treatment could be delayed, and then these delays can cost their sight. And traditional models really just can't keep up with this. So telemedicine changes that game. So with wide field retinal cameras, a nurse or a technician in a rural clinic can capture detailed images of a baby's eyes and send them instantly to a specialist. So this began back in 2008 in India, and there was a recognition they just didn't have enough ophthalmologists trained to manage ROP. So they set up this system with really good results. So they've screened thousands of babies and prevented blindness and really empowered local teams. So with AI now, you can add a new dimension where deep learning models can analyze these same images, detect early signs of disease, and generate vascular severity scores and help standardize measures. And that was shown and this is one publication of many, where a team of researchers wanted to know if AI could detect which premature babies were at risk for going blind from ROP without needing a specialist to examine every child. So they trained this deep learning model, which was FDA approved, called the IROP DL for deep learning. And it was trained on tens of thousands of retinal images from preterm babies. So the AI learned to recognize the telltale signs in blood vessels that signal worsening disease. And it could even assign a vascular severity score, a number that described how sick the retina was, essentially. And to see if it really worked, they tested the system across 2 continents, one data set from the US and another from clinics in India. And the AI performed well in both places. So it correctly identified babies needing treatment more than 90% of the time and could cut the number of specialists exams by nearly 80%. So no infant in the study developed severe ROP without being flagged first. So this is kind of an example of where AI can work really well. It can bridge this gap in expertise, speed diagnosis, and really give these babies a chance for vision. And you might imagine that there could be like a fierce debate about using telemedicine or autonomous AI to screen for ROP. How do ophthalmologists in the US feel about this? But the truth is, this isn't some distant experiment. We're doing this here at home. So at Meritor, we use RetCam images with our tiny patients to help guide care because there's just really not enough pediatric ophthalmologists to see every baby who needs screening. So the technology's advanced to the point where it's not just replacing expertise, it's actually extending it. So it helps us reach those babies who we want to make sure we don't miss, and we want to preserve their vision. So right now, AI is helping us, screen babies for ROP, but eventually it might help us treat them. And so right now I've been in discussion with colleagues in India, so neonatologists, engineers, and innovators, collaborating with the Indian government about developing a low-cost AI-enabled device to prevent ROP. So this is like we want a simple cost-saving device that could really help screen kids in all areas. And so this project's called the Trinity Drishti, so it's in development. But the hope would be we could couple this with AI and have a simple handheld device that then would show the baby's retinal images on a screen. And so that we're kind of in the process of working with folks there to roll this out. And then I just wanted to show you, so I like creating things with art, and there's a lot of tools now with AI that you can generate things. So recently, OpenAI's Sora 2 rolled out. And a lot of folks have used this for humor and things on the web, but I think it does show where we're kind of moving, where you can give text and then generate a video. In this case, it's like a 5-second clip. So this isn't flawless, but it does hint at kind of what's coming.
ROP blinds 20,000 babies worldwide every year. It's preventable, We just need to diagnose it on time.
So, just that's a video I just was able to make with a couple iterations of text, but I thought, this is pretty amazing to think of what that would have taken before to do that. Let's move forward. Okay. So I think, there's a lot of actually exciting work being done in global health using AI technology. And I think there's often a misconception that in low and middle income countries, high tech doesn't have its place, and that we need to kind of recreate the same path we took in the US, duplicating every step in medicine's evolution. But I think that's kind of a silly concept. So now that we have this technology, there's no reason we can't leap ahead and get caught up. So there's this woman, Annie Hartley. She's a South African, but she's affiliated with Yale. So she's doing some really cool work. She's got this light laboratory, and she's proving a critical insight. You in these settings, you can't replace a doctor that doesn't exist. So we worry about AI replacing us, but if there's no doctor to start with in many of these areas, it's really not the threat. They need more help. So in many low resource settings, there's less than one physician per 10,000 people. So in the US, there's 2.6 doctors for every 1,000. So just, such a disparity with resources. And so using AI technology, we can address these unmet needs without a lot of the usual trade-offs, because the alternative is often no care at all. So, and I think the other thing is there's a lot on the line in these settings. There's no safety net if something goes wrong. So really, her team, I love the way they're approaching things with this, really, they want to maintain the highest standards, the most rigorous safety protocols. So they're not just trying to well, this is just good enough solutions. It's really cutting edge technology at the highest level because the stakes are so high. So her team's done a lot. One of the things they've done is this model, Metatron. It's using an open source medical large language model that's been adapted for low resource and humanitarian contexts. So they're conducting randomized controlled trials in Africa, partnering with organizations like the International Committee and the Red Cross. And so they have a bunch of these different models that some can run on phones and some that will be more multimodal. They're more powerful. So they've created these different models for different contexts. And they've also got this, they've labeled this thing called MOVE. It's a massive online open validation and evaluation. So it's a lot of benchmarks for these large language models are essentially, can it pass a medical exam? Can AI pass that exam and do well? But that's not really real world. It doesn't evaluate safety. And so they're kind of flipping this. So including thousands of doctors worldwide, especially in low and resource settings, they're asking Metatron tough medical questions and rigorously evaluating it for safety, bias, and trustworthiness. So then they can develop these personalized chatbots for that location, for that specialty. And so it's a shift from lab-based testing to community-driven, real-world validation, really trying to have the folks on the ground and those sites kind of driving this. And so this is, I think, really exciting work, and she's got a really cool team. So similar to that, I'm doing some work as well in Delhi in India. So in a lot of these settings, clinicians can spend hours each day doing notes instead of touching babies and spending time with them. Documentation is essential for safety and continuity, but it's time consuming. It's error prone and often incomplete. So we asked, could AI take on the paperwork essentially? Can clinicians do less of that and focus more on the patient? So there's a level 3 NICU in Delhi. So we developed and tested this integrated system that combines bedside capture, this system called Trinity, on a clinician-friendly platform, which we've called Impact, and using a multimodal neonatal domain-tuned large language model called Morpheus. And this automatically generates admission notes, progress updates, and discharge summaries directly from the patient data. So using information on over 500 infants, we found that AI produced notes that matched human accuracy, they improved clarity, and they cut documentation time by 76%. So this saved about 1.5 hours per shift for clinicians. And you can imagine in hospitals with limited staff and resources, this technology doesn't replace humans, but it restores it essentially. It gives clinicians their time back so they can focus on patient care. So this is a model too. It's safe. It's a local large language model. It doesn't use the cloud, so it keeps everything there. And so if you had this system, you could use this in the States, but you could pretty much use it anywhere. So since this is a global health talk, we have some sobering numbers. So over 1 million babies in Africa die every year from preventable causes. So these are deaths that, with adequate medical care, about 75% of these could be prevented. So an African baby faces nearly 10 times the risk of death compared to a baby born in Europe or the US. But there's this group with Joy Lawn and others called Nest 360. And so this is a really cool site if you want to check it out. They understand that dropping off donated medical equipment really just creates equipment graveyards in hospitals if you don't have proper maintenance or training. So their international alliance is working directly with African governments to implement a complete package of care. It's based on 3 pillars. So affordable, rugged technologies designed for heat, humidity, and electrical surges. Hands-on education for physicians, nurses, and biomedical technicians. And then locally owned data dashboards that help hospitals track progress and governments reach survival targets. So most approaches focus on single interventions, but really sick newborns have multiple problems that require multiple solutions delivered together. So that's what they're trying to do. So they support 160,000 newborn hospital admissions so far annually, and they've trained 19,000 medical professions across Kenya, Malawi, Nigeria, and Tanzania. And so this group is led mainly by female engineers, physicians, and health experts, partnering with 17 institutions, 13 in Africa, really for sustainable change. And so they are doing a lot of innovation. They've got some really cool technology on their sites. And so I think this is, their goal is really that United Nations goal of limiting newborn deaths to no more than 12 per thousand by 2030. So there's a lot of, like Dr. Hartley's group and this group, there's some really cool work being done globally. Okay, so we're getting close to the end here, and I just want to share a story. So this isn't one that has happened yet, but it could. So let's say it's midnight, and we're in a remote Rwandan village, Rugendabari, and so this is there's a community health worker. You see her kneeling beside a 25-year-old mother who's in labor. So the mom's about 36 weeks gestation, and there's no doctor nearby. The closest health center is miles, and it's over steep, winding roads. But the health worker in her hand, she's got what a lot of us have, right? She has a smartphone. And so these phones we have now, they're essentially mini computers with multimodal capability. So phones often have a lot of this already in them now, and certainly could, with some modifications, could have a lot of powerful tools, such as ultra wideband radar, microphone, it's got a camera, built-in motion sensors. You could have accelerometers and gyroscopes, so our phones can do a lot of this. So it really turns our phone into a miniature diagnostic toolkit. So the phone can emit faint electromagnetic pulses, so ultra wideband radar, and each pulse could bounce off the mother's chest, can measure movements invisible to our eyes. So it can detect heartbeats, so the subtle recoil of the body. So this is called ballistocardiographic effect. So these little tiny motions. The body, even when blood is ejected with each beat, there's some motion. So within seconds, the phone could distinguish, her breathing, and as well as differentiate the quicker pulse of her heart. So the person right there could know what the mom's heart rate is, her breathing rate, right on the screen. The microphone could listen. It could listen to her breathing, sounds of fatigue or distress. The camera could capture her face. It could look at her conjunctiva. It could look for pallor to determine anemia. It could estimate her fundal height from a simple photograph and a calibration card. You could attach a Doppler puck to it. This could send gentle sound waves, reading a Doppler shift of the fetal heartbeat. And within moments, so you could say, okay, the fetal heart rate is 148 beats per minute. Baby's alive with a good heart rate. But the mom's contractions are going stronger. And with a tap, the health worker could transmit all this information, video, audio, vital signs, through a secure encrypted link to a regional command center. So this on-device AI model could summarize the case. Preterm labor, preterm birth kit is needed. And there's actually, this is a real thing, in Muhanga, Rwanda, there is a zipline drone center, and this is a real thing, and they can send, I think, up to 8 pounds of cargo payload in a drone. So this message could go there. They could load surfactant, a suprachoroidal airway device, a cord clamp, antiseptic, oxytocin, and a self-inflating bag, and maybe even a graphene thermal wrap with tiny sensors. So the drone would launch into the night with a ETA of 20 minutes. So this is Muhanga, and the drone's on the way. So while the drone is flying, the mom delivers a preterm baby. So 1.6 kilos, baby's gasping. The phone's camera could activate remote photo plethysmography, detecting subtle color shifts in the baby's skin to estimate heart rate. Radar could pick up chest motions. Microphone could capture the baby's breathing and grunting, determine respiratory distress. On-screen prompts could guide the person of what to do as far as like stimulation and resuscitation. So the healthcare worker sitting there, she gets a tone, supplies will be arriving in 2 minutes. She steps outside, hears a faint hum overhead, and then the drone is going to drop this small package, which she can retrieve drops it down by a cable. Inside, she opens it up, and then she's guided by on-screen visuals and a remote clinician's voice. She gives the surfactant via the LMA, wraps the baby in a graphene blanket, and then begins gentle ventilation with a self-inflating bag. The blanket has sensors built into it, measures temperature, movement, heart rate. All this gets streamed back real time to the command center. Baby's heart rate climbs, baby's breathing better, mom gets oxytocin, her heart rate slows and calms. The phone captures everything with the mom and baby. And then so in this setting, technology could bridge 20 miles of hills and darkness using a smartphone. So combining radar, sound, video, and AI. So it turns that hut in that moment into a mini intensive care unit. So allowing both the mother and the baby a chance to survive. Okay, so we've talked a lot about some technology, and I don't want to miss the chance to kind of highlight some other things that are concerning. So yeah, this is one of my paintings, this little girl in India wearing a mask when I was there in Delhi, I firsthand experienced the air quality, which made me want to I wore a mask as well because of that. And so in our world, we've really darkened our skies with pollution. We've fevered our planet with global warming. We've turned our waters toxic, essentially, and we've laced our bloodstreams with every creature, essentially, with plastic. So some of the fundamental gifts of our planet, where we think of air and water, temperature, things like this, really become, in a way, vessels of harm, and the consequences are written in our bodies and our health. So can AI make this better, or is it going to make it worse? And I think, the power of AI is really undeniable, but so are the weight of its consequences. It can promise better health, but every promise carries a shadow of potential harm. And I think the real danger may not be in what AI can do, but how we're going to use it, how heavy we're going to lean on it. We still need to use good judgment, and I think get involved so we're AI fluent and also appreciating some of the risks. And so I think the ethics of all this is really important. That could be a full separate talk. So we have to think, is AI steering us or are we steering it? And where do we fit in? Are we competing with it, collaborating with it, merging with it? Headlines tell us we're going to be replaced. It can pass boards, but it really, we're not measuring its empathy. And when I have a patient who's, a family who's distressed, let's say their baby's dying or they got really bad news, I'm not just going to hand them a phone and tell them to talk to ChatGPT. I think we need to be involved in the care. And care is really nuanced and more complex. And so I think, you know, and we also have to realize in low and middle income countries, AI isn't replacing doctors because there's no doctors to replace. So how can it fill the gaps to prevent losing child's lives? So I think we're at an exciting moment. I think this is like a renaissance period, essentially. It has the potential to be with AI. And the question isn't really if AI will transform healthcare, it's who's going to guide that transformation. And I think that should be us. You know, we need to be involved with this process, caring for humans behind each data set. So we need to embrace AI as a tool that can amplify our impact, but anchor it in the practice of human connection that defines healing. So what we choose to do today, you know, what we're choosing today to do for children really is going to impact future health and well-being. So I think we really need to choose wisely. And I'm going to stop there and I'll take questions.
Dr. McAdams, that was a phenomenal presentation. You covered a lot and really, as my teenage daughters would say, had a really meta perspective on the potential influence of what AI can do in our day-to-day lives as physicians, as human beings, as well as, considering global impact. I have a lot of questions. I'm sitting in the fundamentals of global health room right now with our course participants who are all feeling inspired. We actually learned about the zipline drone delivery in Rwanda from one of our emergency medical colleagues, Dr. Jessica Schmidt, who spent half of a year last year with her family there doing ultrasound capacity development research. I'm curious about what your thoughts are. And we also just learned Helping Babies Breathe, which is really focusing on that golden minute for neonates globally to help newborns survive. I'm curious about what your thoughts are on how we could potentially use drone technology and AI technology, for example, rural Wisconsin healthcare, as we consider those that don't have access to facility-based deliveries or trained providers in neonatal resuscitation.
Yeah, I think a question with any of this stuff is, trying to figure out like what problem are you trying to solve, right? So I want to be careful not to use technology just to kind of look for problems. I want to figure out, well, what's the problem and how do we solve it? So, some like in neonatology, like Dr. Limjoko is leading the charge with like telemedicine. So we can reach a lot of these settings with telemedicine, and which is great because now when they're resuscitating a baby, I can literally almost be present, right? Like I can listen with a stethoscope. I can be at AFCH and be listening somewhere else with a virtual stethoscope and see things. I think with the VR training, you could do training remotely as well. All they need to do is have a headset. I think depending on like, let's say if someone didn't have surfactant, that's pretty easy to deliver in a drone. I think it's just setting up these systems. So I do think some of this technology is very scalable. I think it's weird because a lot of this stuff seems almost like too futuristic, but they're literally doing this work. I mean, some of this is, if a drone can deliver you like a meal, it certainly can deliver medicine. So I think this is, we'll move in that direction. I think it always comes down to like who's going to lead the charge, who's going to pay for it, what's it going to look like, who's going to regulate it. So I think some of it, I think for me, a lot of this, we have the capacity to do it. Like it's feasible. It's just like the actual implementation piece is harder. So with like a lot of AI technology, we've shown like, yeah, we can probably do this. We need to test it, do it safely, but we need to kind of the implementation piece, the people that are going to do that, approve it, regulate it, monitor it, audit it. I think that's the part that's a little stickier.
Thank you. I'm monitoring the chat, everyone, so feel free to put questions in there. While we wait for those, I'm curious, Ryan, you really highlighted a lot of newborn health initiatives surrounding AI and saving lives at birth. Do you know of any other specialties that have really coalesced in these efforts, similar to what has been done in the newborn specialty?
Well, I think a lot of advancements are, like just in general in medicine, I think the biggest advances have been like in radiology, because these are such powerful tools. So once you get a model working, I mean, it can do 1 trillion equations, in a second. And just to put that in perspective, a million seconds is 11 days and 6 hours. A billion seconds is 31.7 years. A trillion seconds is 31,700 years. So it's doing a massive amount of data in a short time. So it can just screen so many things. And so once it's trained, you have to validate it and you still have oversight, but it can, like with radiology, it's really good at reading images. I think I showed you ROP, but with adults like diabetic retinopathies, it can do a lot with that. It can do a lot with pathology. And now it's like with vital sign trends, it's starting to be used more and more. Hopefully, we'll finally get an AI system in the NICU, but the PICU's got ediometry. They could leverage this, and they've got folks like Neil and others who kind of can use some of their look at these models and do some analytics. Adult medicine certainly is leaning into this. The digital twin concept is happening in adult medicine. Adult medicine often has more money. So I think, and then, when you're partnering with companies too, there's more incentive for them because there's a wider capture and more potentially return on investment, which is often in pediatrics and neonatology, it doesn't seem to be the case. But I think what's encouraging is there is a lot going on. I just met with someone the other day from Indianapolis. He's a neonatologist there, but he's from Nigeria, and he has all these ideas of like work he wants to go back and do multimodal kind of work, looking at babies early on to do screening in Nigeria. So there's a lot of, I think, folks with creative ideas. It's just, I think, partnering with the right people to like be able to do the work.
John, we'll take your question next, and then I'll keep monitoring the chat.
Thank you. Fantastic talk, Ryan. Amazing technology. It's incredible promise for low resource settings, and I love the fact that you emphasize that the human aspect is critical, and that's not going to change, I think, anytime soon. Not in my lifetime. Maybe in some of you all's lifetimes. I have two questions. One non-science, one science. The non-science is I love all the art during the talk, so I'm curious, like, where is that all yours or where it came from? The science question is, we're all incredibly familiar with AI hallucinations and outright fabrications. So what about that aspect of AI in healthcare? If the AI gets it wrong and there's nobody checking.
Right. Great questions. So the art, some of it was paintings that I did. A lot of it is I like Midjourney a lot, so that creates some really cool generative art. You can do so many things. I can take my art and then train it on that style and then make new art. I can give it iterative prompts, and I've kind of come up with styles that I can use. Now you can do, like you could see, I can have the painting become alive. So I can take a painting I did like 20 years ago and feed it to it, and then have like the person in the painting moving around and walking. So it's pretty like crazy some of the things that you can do. Some of these slides, I'll spend an hour finding the right image. So you can kind of get lost in it, but it is pretty powerful with what you can create. And there's a lot of different software for this. The nice thing too is like a lot of these, whatever you create, it's yours. So they're like, I've read all the rules, so it's like it becomes your art. So which is kind of nice. But I don't claim, oh, like that's mine. It's like I use this software to get this versus something I actually painted myself. The hallucination question is really important. One of the reasons I like that Annie Hartley and her group using their model. So if you take something like a retrieval augmented generative AI, so like a RAG system, you can give it a corpus of information. So I could have a good example is like if folks have used Open Evidence, right? So Open Evidence right now, if you haven't used it, it's a great tool. It's pulling all its, like if you query it with a question, you have a question about, let's say, type 1 diabetes or something, and you ask it, it's going to give you references that are real. So it's actually partnering with JAMA, with the New England Journal. It's pulling from PubMed. So it's not fabricating the results. Now you can still fact check if you want its interpretation, but it's pretty solid. That's different than if I use ChatGPT or Claude or one of these other programs and say, okay, give me some information, and it gives me a list of references. And they look good. They look like I recognize that author, I recognize that journal, but then I look it up and it's not real. And then you can ask it like, hey, these aren't real. And it's like, oh, I'm sorry. And then it can still feed you. Sometimes it gets stuck in this hallucinative path and it cannot get off of it. And you almost need to start over. Sometimes what I'll do is I'll fact check it. I'll say, pull up these references for me, show me where they came from. And I make it go through every single one and validate it so that I can fact check it. Now, the problem with that is you don't know when to trust it, when not to trust it. And I think that's the problem, right? You want to be able to lean on it and trust it. I mean, even with like the way we do medicine now, like some of the papers, they get published and it's not good literature, right? So I wouldn't call that necessarily a hallucination, but it got through peer review, but it doesn't mean it's perfect. So I think that's where it's really important that we still have our critical foundation. Like we cannot lean on this and just have like, okay, I'm just going to trust it for everything. Whatever it tells me, I'm going to believe it. Because I've given it board questions before, and it gives me this amazing answer, and I'm convinced, and I'm even like, oh yeah, I guess that's the right answer, and it's wrong. And it's like, oh, it can mislead with confidence, right? So I think that's the problem. I think they've worked on this, so it's gotten better. But I think especially in medicine, why it's so important, I think, to validate and train these models and do it the right way and have us involved is to kind of like our tendency for bias, and and also to catch that hallucination. So I think we have to have a high bar. The flip is there's this tension because let's say if we were honest, our metrics, like, well, Ryan, how good are you at actually like predicting this or doing this? I'm like, let's say I'm like 75%, right? And I think I'm 100, but I'm 75. And the model's consistently 85. Like, if you do numbers on patients, it's like safer to go with the model than it is to go with me. So maybe together we're better. So I think it's figuring out more honestly how we are from a performance metric standpoint with some of this. Where does the model where is it at, and then audit it and then have it running maybe in the background for a while to see like where does it go off the rails? Can we correct that? Can we fine tune it? But that's a really important concept. I mean, but that's why we have to stay involved and not just like, I'm not just going to trust Sam Altman to give me the algorithm. I got to be involved.
This is great, Ryan. We have a lot of questions coming in. The first one is, are all intubations at UW and Merritt done with AI assist? If so, do you feel that residents and fellows are still getting enough hands-on training with intubations without AI assist? And when they go out into the real world,
none are done with AI assist.
Okay.
So the way we did this, we got IRB approval to look at de-identified video. So we're just looking at an airway. And then we're training the model. So this is like pre-FDA, this is preclinical. So this is more of a knowing we have this technology and knowing where the future could go. What can we do, not with direct patient care, but to like see how this would perform. The goal eventually, you'd have to go through all the right channels, FDA and everything else. But where you could envision a future where you're going to intubate with video laryngoscopy, it's assisting you to help with that. And so it's not necessarily doing the intubation for you, it's kind of guiding you through it like an expert would be there, extra set of eyes and giving you prompts. I think the reality is there's this rub of like people aren't getting enough procedures. So are we making that worse? I don't know. I mean, I think it's like technology's changing. Like we do almost all our intubations with video, but like a couple years ago, people were like, no, we got to do direct. I'm like, why? Video's on a big screen, everyone can see it. You know what you're doing. It's safer, it's better. So I think there's sometimes with any change in technology, there's a pushback, right? When the calculator came out, it was banned, right? And so it's just figuring out, I think, what do you need for the different settings? And also if this technology becomes scalable, then you have this in different settings. If anything, I would argue if I'm in some rural spot and the last time I intubated was 10 years ago, and you can give me some device that literally can increase my success rate by like 50%, wouldn't I want to use that? So I think it's just figuring out the right way to do it, but asking questions like that of like, I'm not just like, oh, AI is great for everything. I'm like, it's good for some things. My main message is we need to be involved with how it rolls out instead of just like, it's kind of like the HR. Here you go, use it.
And Ryan, Dr. Green is curious, how do we use AI and continue or enhance empathy and communication with patients and their families?
That's a great question from Dr. Green, and nice to see it or hear your name, Dr. Green. Well, that's where we have to step up. I mean, it's kind of like, that's on us. Like, really, do you want it to be, here's your empathy, it like can write a great email and it can actually sometimes probably have better empathy than some of us, to be honest. But I think you have to say, like, how do I get better? I think for me, it's using the technology actually to make you better. So I can, one of the projects I was working on with some students is like, could it watch me do something? Can I, can I go through a simulation where I'm breaking bad news or talking to someone? It can measure the tone of my voice. It could look at me. It could see what I'm doing, and it could coach me and say, "Hey, you weren't showing empathy right there, and here's why." And it could point it out, and then it could work with me, and I could do all these different role plays and scenarios, and eventually I get much better at it. So it's a safer space to practice that than real time. But I think for me, like the whole point is like I still think one of the best tools in medicine is a chair. Go sit by a family and spend some time with them and get to know them and listen. Like you use your ears, you got two of them. Don't use your mouth as much. And I think some of that is just like our presence is really important. It's hard to teach that. I hope we role model that, but that's probably the most important thing going forward is like empathy. And it's what I think our patients would be like, yeah, if you give me this algorithm that's going to 99% of the time be right. Great. We want you to use that. In fact, you better be using that. But I think they don't want me to hand them a phone when I should be giving them a hug, right? So it's kind of like we need to be the person that does that.
Ryan, thank you. We have a few more questions in the chat, but I want to be mindful of the time. It is 8:30, so those of you that need to hop off, feel free to. And thank you so much for attending today's Grand Rounds.
Yeah,
Those
thanks
of
a
you that
ton
want to
for-
stay on for questions, we can address a few more on the Zoom. And thank you again, Dr. McAdams. This was a phenomenal presentation.
Thanks, Nikki.
Ryan, one question we have from Jalal here in the Fundamentals of Global Health room is what kind of internet is required for this technology to work? For example, can it work over cellular data? Some of the things that you're proposing.
Yeah, so different models can be, more local. And I think, for the most part, I think you just need some Wi-Fi connection. I mean, there's a lot of different types of models that can run in different capacity. Like the large language model, Jetson, NVIDIA computer we have for that site in Delhi. That probably costs maybe like 2K, but it can store everything, run everything locally. They just need to have a Wi-Fi connection. So some of it, I think, there's different ways this technology can work. I think it probably depends on like, what you're trying to achieve. Dr. Hartley's group and everything, they're doing this in, they're focused on settings like Africa to make this work. So I think there's a lot of really smart folks who are focusing on different settings to kind of be able to pull this off. So I'm pretty confident that that won't be a barrier. With some of the VR work, you have to have a computer that can handle, I'm doing some stuff on a phone, but I also have some pretty powerful laptops that, have like NVIDIA GPUs in them to run it. So I think that's always a question I think to be asking is like the thing that you're working on, who are you excluding and who are you including? And I think these are some basic questions you want to say before you're doing some of this technology. So it's a good question.
Ryan, I know you're on service in the NICU. Do you need to hop off or do you have time for a few more questions?
My colleague Adam Bauer is going to he'll be okay by himself for a bit, I think.
Okay. And again, whoever
for
needs to
asking.
hop off, feel free to. And friendly reminder to please also complete the evaluations. Rowan, also in our room, is curious about in low resource settings, particularly those affected by political instability, the implementation of such technologies may raise security concerns or provoke resistance from governing bodies. How do you anticipate addressing these potential challenges when introducing this technology in such contexts?
Well, that's where I think here, even in the US, like what level of transparency? I mean, I'm pretty disappointed with a lot of our companies, some of the choices they made. Like OpenAI has like 700 million daily users. It's massive, right? So billions of prompts per day. Um, they just said now they're going to start allowing like adult content and stuff. And I'm like, they said they wouldn't do that a year ago. And it's like, well, I want to solve, how do we figure out, curing cancer, not like promoting porn kind of thing. So I think some of these tools, the problem is, money is and investments drive so much of this. And when there's trillions of dollars, that's the carrot over the stick. It's going to make some choices, I think us as pediatricians wouldn't necessarily agree with. On a government level, there's been different stances. We have states like California has been pretty forward. They just introduced two new bills last month with AI regulation. The White House actually like almost took away regulation. So we were having like just chase this artificial general intelligence. We want to be the first to win the race. You know, China's doing this. They're putting a ton of resources in this. You know, you're hoping folks are doing this ethically. It's not like they've consented humanity to what they're doing, but we're just going to be kind of victims of this potentially. So I expect some good and some bad. What's kind of scary is Sam Altman in a recent interview was even like, yeah, this is going to probably screw up and it's going to be scary. And it's like, you know, wait a minute, they're the person in charge of this. Maybe can you have some more safeguards in place? I think how this can roll out in some other settings. I mean, some governments have put a lot of rules and regulations on it, others haven't. It's like any technology, like just think of with our phones, with just all the things you can do with it, good and bad. That's happening. It will continue to happen. It's also, I think, why if more folks get involved and become AI fluent, we have a better chance of kind of knowing about it and influencing it. But I do think those are actually very valid concerns of like, how is this going to affect different populations? I mean, my biggest worry is it's going to widen gaps, not narrow them.
Really interesting perspectives. And I think Christian Olsen also brings up a important sort of historical and ethical consideration in that she recently attended a talk on AI for AAC users. And Rua Williams has a book on eugenic histories of some of the origins of AI, and she's curious as to what we think we should be mindful of when thinking about AI origins.
Yeah, you know, most of these models
Yeah,
were
I can
developed.
come off of mute.
Oh, go ahead.
Oh,
Yeah, go
sorry.
ahead.
Hey, Ryan, I went to this talk by Rua Williams yesterday, and I was thinking about, the conversation that we had earlier in the week and then
Uh-huh.
or last week. And then specifically, they brought up the way that AI is being most operationalized by corporations is the example that they used was insurance rejections. And so, and the eugenic histories of some of the founders of, AI. And so I guess specifically around insurance and, health insurance, and then the role of physicians in helping, patients
Yeah.
get the treatment that they need, and that AI, that if that is what AI is being used for, like how do we counter it, or what ways are there to be involved so that it is used ethically in our healthcare systems?
Yeah, I mean, these are things I think about a lot, and I think what is a little disheartening is kind of, you know, the level that these decisions are being made is so high above us that they're rolling out so fast that it does bring concern of what this could look like without these things being transparent or really validated. You know, they're already using it for like, I think Medicaid. So it's you can see why they'd want to use it, right? It can do so much work at a lower cost. It eliminates, you know, you can it's sad to say, but you don't need certain human workers and paying their salaries and their insurance and all that, and it can automate a lot of this. And so they're going to use this. This is the reality of where we're at. I think how the models perform. I mean, most of the models just essentially scrubbed everything on the web. It mirrors the web. So it also mirrors some of the worst parts of us as humans. They have human auditors that then try and like fine tune these models and see where they troubleshoot. The models, they change too. You can see their personalities change with new versions. And so, but some of the algorithms used, you want to make sure that those don't have bias in them that would exclude care for certain people. Or, you know, this has happened with the legal system. You know, that's been around for a long time now for like deciding recidivism and who's going to, oh, so if you're like an 18-year-old black man, maybe it's going to make a different decision than if you're an 18-year-old white man, which is like not good at all. And I think we have to worry about that within these models. And so like some explainability, I think there needs to be enough transparency that the majority of us could look at it and say, yep, I get it. You know, you're not going to be able to explain all like billion nodes that are going on in that model. Like there's just too much information, but you need to know some aspects of it to kind of see how it's working, audit it, change it, monitor it. I think the problem I've kind of been preaching about for the last few years when I go to these conferences is like, I'll say, hey, raise your hands if you've been involved in any of the development with Epic or any of this, and no hands go up. Well, because we're not being involved. It's like this handful of people, and Epic's just rolling stuff out. I got nothing against Epic, but it's like it's just an example of some of these big companies. They've got a ton of data. They've got our data, which they never paid for. They just have it. Now they've got these super powerful models and they can sell this. And so it's not, this isn't like conspiracy level thinking like they're all bad, but they are being driven heavily by investors. And there's a lot of pressure to perform. And AI is such a hot topic now that everybody wants it. So I do think I worry with that, like what that might look like. You know, you'd hope that it had the chance to get it right. And I think there are folks though trying to do that, right? There's like, you know, so we're not kind of repeating colonialism with AI. I think in like that's why Dr. Hartley and others were, you know, they're this is centered, let's say, on the African content with African people. Their pillars are all like, okay, that all sounds great. And they're like empowering folks there and training models locally so they can be used locally. Like that feels like great. This is a powerful tool that's really empowering people, benefiting them. Still could go off rails. It needs monitoring, but it's that system's designed for those folks to optimize things. And I think we're not, I do worry in the US that's not going to be the case. And so this is kind of where this is, I mean, part of my message is like, what are we going to do about it? That was my quote with Gandhi, kind of to start with. It's like, are we going to be passive about that or be more active? And let's be real, like what's going on in our world right now with our government, like you can't even keep up with all the changes and the things that are being dismantled, you know? So it's in some ways a scary time, but I think now more than ever we have to figure out ways to kind of like, especially as pediatricians, like what are we doing together to make this better?
Ryan, and friendly reminder everyone that you can feel free to hop off when you need to. Clearly, this is a topic of discussion that many people want to stay on for. So kudos to you for really helping to facilitate this, Ryan. And Riva and Mala, just let me know when we need to close things down. There are two more questions that are in the chat. Are we okay?
Maybe two more, and then I got to head into the unit.
That sounds
Okay.
good. One of
Sound
them
good?
was if you could design an AI research study for neonatal ROP or another area of study that could use more implementation of AI from scratch, what question would you most want it to answer?
Wow. I feel like there's already a lot in the ROP. I mean, there's a lot being done with ROP, so I feel actually, fortunately, that's an area that's advanced a lot. So I don't think that's what I would tackle. I think I would figure out how to prevent prematurity. You know, how do we do that? Because if we can keep the baby safely in the womb, so much of this stuff's like that's the main cause of death. It's the main, you know, it puts the moms at the risk and babies at risk. And so like that's what I would study is how do you figure that out? And I think with some of the omics data that we know, I mean, we get like think of these, you know, if you have like genomics, transcriptomics, metabolomics, lipidomics, all these omics, you've got this massive corpus of data and you've got this really powerful tool. And if you apply some of that technology to this and study huge populations, you could probably start to figure out mechanistically how to prevent some of these things. Just like they're discovering new drugs, new antibiotics, things like that. I mean, they can do like literally like billions of calculations, which would take decades of work in a lab, and they can do it in like weeks or months, right? So it's this accelerated time scale to get an answer that like just through, you know, using computer algorithms. I think I would try and tackle like big global problems. Let's get clean water. Let's improve air quality. You know, the problem is in this process with AI, we're using ridiculous amounts of water, like trillions of gallons of water um, every year just to kind of cool these things. There's a lot of evaporative loss. There's a ton of energy consumption. So the thought is like, well, no, once we figure out AGI, then we'll solve all the problems that we're making. I'm like, maybe, like, you better hope so. So I think the problem is like, as you're building something, you're destroying something, right? You know, is it like, how are we doing this? And along the way, can we have more like closed loop, recyclability for water. Like, how do you create systems up front? I mean, this is like, to me, ethics embedded in AI up front instead of on the back end. Like, embed these systems up front so that right from the start, you don't even get to start in it until you can show me you're not going to like, burn as much electricity as like, 100 cities kind of thing running these models. Like, you need to like upfront show that instead of like on the back end. The problem is it's capitalism. It's the money behind it. It's like, well, we're going to figure that out later. I want to make money right now. And that's kind of how we roll as humans, right? And so I think that's the problem. And so I think there is definitely some consumptive, the training of these things costs a ton of money. The daily use is not as much, but if you have 700 million users, and every prompt is essentially like 3 seconds of a light bulb being on, well, do the math, it adds up. So I think we also have to be really like honest about the environmental, carbon footprint that we're stomping right now by doing some of this, but it's not going to stop it. So I think you have to just, this is also where like, who's getting involved to kind of raise some of these concerns.
Ryan, thank you. I'll launch into the last question before I do so. I just want to thank you for thinking and dreaming big on all of our behalfs. This has been really an honor to hear and an honor to be your colleague. The last question is from Cast Window. I've heard some concerns from environmental protection groups that AI-generated tools, specifically ChatGPT, use a significantly greater amount of power electricity, similar to what you alluded to, than a Google search or existing search models. Have there been talks and considerations of environmental impacts of these newer tools?
Yeah, I mean, kind of what I just said. There's definitely a recognition. It's certainly not stopping anything. And like a lot of the companies, they'll say like they're going to have some system in place, but I think Meta has like a server farm the size of Manhattan. I mean, these are like massive geographies of like just computers. They all need to be cooled, so they got to extract a ton of water. A lot of that's lost to evaporative losses to keep them cold. There's a ton of electricity. So what is that having, like in some areas where there's drought, and then you're thinking like you're doing this, and then there's also some, hardware to think about. So I think this is something that probably isn't discussed enough, and there is some information, there's some papers on it. I think it's just how do you kind of when you have a government that's not going to do anything about it. I mean, like, let's think about the reality right now. Like, now we're saying climate change isn't real. Like, if you think of some of these statements and like how we're kind of dismantling stuff, the goal has been like widen the road to let this stuff happen, and there's no toll booths or nothing there's no speed bumps to slow people down or speed checks. And I think that's the problem. So I think we have to, um, I mean, I think grassroots, like raised awareness is important. And then if enough people get behind it and demand it, then they'll do something about it. If we're more passive or we're just ignorant of it, then it's going to be 10 years from now. You're going to be like, oh, did you know you did this? Or did you know this happened? And that's kind of like how we've done things historically, right? We're not really as proactive on the front end. We love to do preventative medicine, right? Like Earth would have liked preventative medicine, we wish we would have started a while ago. So this is all kind of after the fact. It's kind of like our HIE babies. I can't prevent it, I treat it afterwards. We're kind of doing that with the Earth. So I think important questions. I don't pretend to have solutions for all that, but it is something I think about a lot.
Thank you so much, Ryan. Huge
Yeah.
applause from all of us.
Cool. Well, thanks everybody for sticking with me.
Have a great day, everyone.
Yeah, bye. See you, everyone.